What I'm going to do, our new format since last time was for me to cover some aspect of Parkinson's disease, then take some questions. The last time I spoke about the diagnosis of Parkinson's disease, how we make that diagnosis, and how we can distinguish Parkinson's disease from look-alike diseases. You can't hear? Okay, I'll hold it closer to my mouth. Yeah. Thank you. So now I'm going to speak about the natural history of Parkinson's disease. And by that I mean, how does the illness develop over time? So as you all know, it begins with very subtle symptoms. It's insidious in onset. It sneaks up on you and is often interpreted, the earliest signs are interpreted as just normal aging. Of course, I'm a little bit slower. After all, I'm 65 years old. Now, 60's the new middle age. It's not old, but that's about when that's the average age at which Parkinson's disease is diagnosed, 60. Of course, we see people 26 diagnosed with Parkinson's disease. That's rare. People less than 40 are diagnosed with Parkinson's disease. And that's about 8 to 9% of all cases of Parkinson's disease begin before the age of 40. And then people who develop Parkinson's disease at the age of 80 is less. Usually when the diagnosis of Parkinson's disease is made at 80, in other words, the symptoms began from 80 to 85 years of age, it's usually not Parkinson's disease, but a mimic of Parkinson's disease, and would not be treated exactly the same way. But I'm going to talk about Parkinson's disease and how it gradually changes. And the reason I'm going to describe that is because the way one treats it depends on the stage of the illness. So the very earliest stage of the illness always begins on one side of the body. If the first symptoms you notice are on both sides of the body, then it's unlikely to be Parkinson's disease, or you were a poor observer. What usually happens is people will not notice symptoms on their non-dominant side because they don't use that non-dominant side. In other words, most people are right-handed. But if the symptoms begin on the left, as decreased dexterity of the left hand, you may not pay much attention to it because it's not impacting your handwriting or fine motor control that you do mostly with your right. You may begin to notice it when the right side is involved. And by then, of course, a year or two has gone by. And you'll say, yeah, I have symptoms on both sides. That's how I first noticed it. It's very important to recognize that the illness always begins on one side. And what are the first symptoms on one side that one can see? By the way, the disease of Parkinson's disease does not begin with a gait problem. If the first symptom is problems with walking, first thing that is noticed by you or your family, either you're not good observers and ignored what's happening with your arm, one side or the other, and only when you noted there was a gait problem did you recognize something was wrong. That's unlikely to be Parkinson's disease. The gait disorder, this one I'm going through the natural history, is phase, I'd say, comes on later. However, if you're 80 years old and the first symptom that's noticed is small shuffling gait, but no problems with the arms are good and loose, that's called lower body Parkinsonism. And that's about 8% of all cases. And that's different than Parkinson's disease. So, getting back to the classical form of the illness, begins on one side of the body. And everyone, of course, even James Parkinson pointed this out, there can be tremor on one side of the body. It could be the hand or the foot. And it's a tremor at rest. So if you're using the hand, there is no tremor. It's when you're not using the hand that the tremor is noted. Or if you're sitting down and the leg starts tremoring, that's a rest tremor also. But if you're walking, you won't see the tremor. If you're walking and you see the tremor of the hand, that's a rest tremor of the hand. However, and James Parkinson emphasized, rest tremor as one of the classical signs of Parkinson's disease. On one side of the body, eventually, with time, the tremor becomes evident on both sides of the body. That's called stage 2 of the illness. Stage 1 is the symptoms are on one side. Now let me tell you a bit about tremor. Rest tremor is key. It's not a tremor that you notice when you go to drink or use your hand to dial a phone. That's called an action tremor. That's not typical for Parkinson's disease. That's typical for essential tremor, the most common movement disorder. Another thing you should know about tremor is that it's not necessarily present in classical Parkinson's disease. About 1 out of every 3 patients who has classical Parkinson's disease has no rest tremor. So tremor is not what I use especially to consider the sine qua non of Parkinson's disease, without which there is no diagnosis. Not true. You can have only 2 of 4 cardinal signs, and I'm going to describe what they are. Right now I told you, begins on one side, that's key, gradually begins on both sides. If it's tremor, it's easy to notice. It starts with maybe just a little finger tremor. Classical description is this kind of tremor. Pill rolling. Well, who rolls pills anymore? Just the old pharmacists used to prepare their own pills, and they'd be rolling them. So that's called a pill rolling tremor. But the tremor can start in the jaw. Then you wonder, well, wait a minute, you said it has to start on one side of the body. It's very unusual that the first tremor is in the jaw or the lip. But occasionally, that's the first thing. And you can't tell if it's right or left. But eventually, that's a little tricky thing. But remember, you don't need tremor to be present for the doctor to conclude that you have Parkinson's disease. So the 2 most important signs of the illness are, and I think the most incapacitating aspects of the illness are, the slowness of movement and the rigidity. Now, because of slowness of movement and rigidity of muscles, by rigidity of muscles I mean a kind of stiffness, and because of slowness and rigidity you lose dexterity. So we don't say, oh, loss of dexterity is one of the hallmarks of Parkinson's disease. Yes, it's there, but the hallmark is something more fundamental. Slowness of movement and rigidity. And what do I mean by slowness of movement? It's a more complicated. This would be slowness of movement. Right? No one moves like that. But if you look at Parkinson's disease patients, when they reach out, it is slow motion. It's slow motion as opposed to doing this. And in addition to slowness of motion, of movement, there's difficulty to initiate the movement. It's part of the slowness rubric. So there's slowness of movements, usually on one side of the body at first. Then eventually both sides become slow, and then eventually the whole body and all movements become extremely slow. And another important aspect of slowness is the difficulty to initiate the movement. So there's a big delay. You're going to get up. There's a big delay, and then sometimes you can't even initiate the movement. In some exaggerated cases, we call it gait ignition failure. And there is a real entity like that. It's a really bizarre form of Parkinsonism where the gait ignition is very, very prominent, where it's, of course, very slow to get up, and then it's just hard to initiate the gait. Well, typically that is the predominant symptom, gait ignition. It's usually not Parkinson's disease. Later on in the illness, the difficulty in initiating movement is evidence in Parkinson's disease. But there are some individuals, especially the late onset cases of Parkinsonism, in other words, mimics of Parkinson's disease, that I told you began in the lower body, they're typified by gait ignition difficulties. There's another condition that mimics that. It's called normal pressure hydrocephalus. It's where there's an accumulation of cerebrospinal fluid in the ventricles, and it causes neurological deficits of cognitive decline, gait ignition problems, small steps, and they're often misdiagnosed as Parkinson's disease by ignorant neurologists. But what I say is that
if a person gets up and you see this kind of thing, then when they start walking, I'm going to put this down so you can see. By the way, we all who teach movement disorders have to mimic the movement, so I'm going to do it for you. So, see what I'm doing? My arms are loose. That's called lower body Parkinsonism. That's exactly how vascular Parkinsonism patients walk, and exactly how normal pressure hydrocephalus patients walk. Arms are loose, it's tiny, and then if they're going to turn, they can fall forward. In Parkinson's disease, there's a small steps as the illness is advanced. We'll get into that. I'm still in stage 2, but I'm talking about the gait. They have a flexed posture, and one arm doesn't swing as much. So this is the difference. You see, the arms are flexed and the arms don't swing, as opposed to. Okay. So one has to observe all of these things. So I've only gotten to stage 2 of the illness. Stage 2 of the illness is there are symptoms on both sides of the body, and the symptoms have to include the classical hallmarks. Slowness of movement now involves both sides, and the rigidity on both sides. Now, rigidity is something that people with arthritis might complain of. I wake up and I'm stiff and achy. My bones are all fused, you know, that kind of thing. Well, that's not the stiffness that I'm speaking about. Stiffness is what is detected, we call it rigidity. It's resistance to passive movement of a limb across a joint. So many of you who've seen me or other neurologists will see the doctor hold your wrist, put his hand on your biceps, and flex your arm back and forth. He's looking for resistance. And oftentimes people will just get tight. Just relax, and I look for how much muscle tone there is. If there's resistance of a specific type, we call cogwheel rigidity, where it goes in steps. That's called cogwheel rigidity. It's one of the classic signs of Parkinson's disease. So along with the slowness of movement, cogwheel rigidity on one side of the body, that would be phase 1, with or without tremor. Tremor is not that important, but we'll bring it up later on when I talk about treatment. So cogwheel rigidity and slowness of movement may be the earliest symptoms that you can detect on one side of the body. With time, that slowness of movement and rigidity affects both sides of the body. And just around that time, when both sides of the body are affected, one can notice a marked change in gait. Now, early on, I said, don't ever believe that the illness begins with a gait disorder. If that's the predominant symptom, it's not Parkinson's disease. It's probably lower body Parkinsonism or normal pressure hydrocephalus. But there is a gait disorder early on, but it's subtle. And it's what it is that because of stiffness on one side of the body, you may notice that a person walks and they're not swinging one arm. So this is what it looks like early on. So, and then also, when the leg kind of is dragged a bit, almost like you got a sore hip. That may be the worst of the gait disorder you see in the early stages. You don't swing an arm and the leg is a little stiff. It's different than this that you all associate. It's different than this. It's just arm's not swinging, the leg is not as smooth in its movement. That's the extent of gait disorders in early Parkinson's disease. It's not a prominent symptom. So if you tell me the first symptom that you saw was, I had problems with walking, well, people with the early stages of Parkinson's disease don't have a problem with walking. So that's why I always say, I'm as good a doctor as you are a historian. If you give me garbage history, I'm going to come up with garbage diagnoses. And one of the things that impressed me, I spent 3 months in England as a medical student, was how articulate the British were in giving their medical histories. I just don't know why. When I get histories in the United States compared to the patients I saw in the UK, it's almost like veterinary medicine. Well, what I mean is I get no history.
Or the history, oh, I don't remember. Oh, what year did this? Oh, you know, ask my wife. You know, or I don't know. And then I said, I brought all my records. You find out. So I get a stack of records, and no one ever records when the first symptom began. And whether it was a gait problem, was it a problem of rest tremor, was it decreased dexterity? Now, remember what I told you at the very beginning. Slowness of movement and rigidity results in decreased dexterity of the hand. So then there's all the ancillary things that go on with decreased dexterity. So then I'll ask, can you cut your own food? Is your handwriting changing? Can you do buttons? Right? Now, if you're right-handed and your symptoms begin on the left, that may not be impacted. But one of the classic kind of superficial manifestations of illness is the changing in the handwriting. Where if you were to track a person's signature over 10 years, you'll see that the person's handwriting who's developing Parkinsonism gets smaller and smaller, this micrographia. And it's why? It's not that their vision is poor, it's that the slowness and rigidity of the muscles of the hand is impacting the handwriting. It's no longer fast, it's tiny, it's because all amplitude of movement is diminished. So, there's another aspect of the signs of Parkinson's disease that is quite intriguing, that isn't part of the classical 4 signs that I always speak about: slowness of movement, cogwheel rigidity, rest tremor, and then loss of balance is one of the later things to develop. But it has to do with the amplitude of movement, how big a movement. And this is why in physical therapy we stress big movements. So in addition to slowness and rigidity, all movements become smaller in amplitude. So one of the things I always ask, and all neurologists ask, have you finger tapped? At least 10 times, real big. What happens is the amplitude gets smaller and smaller. And foot tap, amplitude gradually diminishes. That is another manifestation of the illness. So the amplitude of your handwriting gets smaller as you start off okay. As you write the sentence, it becomes almost negligible. And it's kind of a subjective complaint that patients have, is that they're easily fatigued. So it's as if the hand fatigues as they do repetitive hand movements. I can do this for a long time, but a Parkinson's disease person gradually gets tinier, and then they have to rest a moment, then they can start again. And the same with all motor action. Easily fatigued, amplitude diminishes with repetition. So now the illness is on both sides, and the next thing that you notice, the next important part of the natural history, I'm not talking about treatment yet, I'll tell you how to treat each of these different stages, is the loss of postural reflexes. In simple words, that's the 4th cardinal sign. It becomes evident after the illness has become bilateral. The next stage is the loss of balance. And it's independent of other reasons you lose your balance. So there are many reasons people lose their balance. In fact, falls are inevitable when you get into your 90s. I've never seen anybody in their 90s who's not very much in danger of falling. And the reason is they don't even have Parkinson's disease, by the way. So they have problems with their peripheral nerves that carry sensory information to the brain that lets them know where their body is in space. They have problems with their inner ear, which gives the body sensory information as to where your head and body are in space. It's the gyroscope, so to speak, the vestibular system. And they lose vision, which allows you to keep your body in space. If you have problems with all 3 systems, you'll fall. And that is a sensory kind of falling, where sensory input is diminished. In the case of falling in Parkinson's disease, it has to do with the central processing of information that lets you automatically execute learned motor programs. So it's part of the loss of the dopaminergic system. You lose the ability to recover automatically. The motor component of recovery, of loss of sense of balance. So that is stage 3, the tendency to lose the balance. And at that point, we start saying, well, we need additional sensory input to help you. So sometimes a cane or a walker used intermittently, especially if you're going to be walking a distance, like in the mall. And then stage 4 is when, because you've had a number of falls and your frequency of falling is increasing, you probably need to be in a wheelchair a lot at stage 4 of the illness, where it's dangerous for you to ambulate without assistance. But there is ability to transfer, to walk short distances with a walker and then to use a wheelchair for other times. Stage 5, which I rarely get to see in my clinic, stage 5 is the stage in which they really need help for everything. It's the stage where there's a danger of choking on food, developing pneumonias, developing all kinds of other complications from the paucity of movement, the inability to clear the secretions, and the tendency to fall frequently. So that's stage 5. Stage 6 is when we meet our maker. And people don't usually talk about that, but we can talk about how you leave stage 5, which is existence on planet Earth, and stage 6, where we all meet our maker. So usually I never talk about how one dies with the illness, but we'll save that because it's important. One never really knows how one will meet one's maker. It could be on the highways, like today, coming down, I saw a nasty accident. It could be any number of ways. The good news, and now I'm going to talk about how you treat and when you treat. The important thing is that how you treat. Everyone kind of knows what medicines we have available. It's when do you use those medicines? A lot of bad docs, as soon as they make a diagnosis, because they find 2 of the 4 cardinal signs, aha, you have Parkinson's disease, I saw it from the moment you walked in. Here's some Cinemat. That's a mistake. You don't immediately treat the diagnosis. You have to inquire of the patient and the family what functions of everyday life are affected by your symptoms. So, and that will determine what the first drug to be, when to use the drug. So the presence of slowness of movement and rigidity and tremor on one side of the body involves the left side may not warrant treatment because the person is a salesman and can write perfectly well all the orders and can function very well. So I may not want to start levodopa in a person with stage 1 illness that affects his non-dominant side. I may, however, give him something that we think may slow the ongoing progression of the disease. So I might use albupril or selegiline, low dose once a day, or Azilect, 1 milligram once a day. Because there's evidence that people in the early stages of the illness can have a slower progression to the next stage by taking these MAO inhibitors. Now, let's say the symptoms are on the right side of the body, and the person is likely, the symptoms are mild, but he's having problems. His supervisor is saying, you're too slow in getting your work done. That person, I might want to initiate levodopa right away, even if they're, 40 years old, 50 years old, because they can improve their dexterity with a judicious dose of levodopa carbidopa. However, if there's a rule of thumb. If someone is 60 or less but needs dopamine replacement, or because of their compromised ability to work, then we'll use a synthetic dopamine instead of levodopa carbidopa, known as Cinemat. So we'll use Requip, ropinirole, or Pramipexole, Mirapex, or in the older days, bromocriptine, or the patch, Nupro. These are drugs that mimic dopamine and do not have to be metabolized by the liver. They're not affected by your diet, and they're less likely to produce the levodopa-induced dyskinesias that levodopa will do. So there are 2 key issues about when to begin treatment. It's the age at which you want to treat the patient, at the age of the patient, and secondly, whether or not their symptoms are interfering with function. So if someone's less than 60, I'll use synthetic dopamine. one of those agonists. My favorite in the last few years has been the Nupro. It's a 1-a-day transdermal delivery, which is very convenient, hard to forget to take. If one is 60 or more, and remember the average age at diagnosis is 60, I'll go immediately to levodopa-carbidopa. The chances of levodopa-carbidopa producing dyskinesias when you're beyond 60 are less. If you use levodopa-carbidopa in a 30 or 40-year-old, they're the ones who develop the worst levodopa-induced dyskinesias. It's one of the things you might have noticed in Michael J. Fox. He had a lot of excessive involuntary movements. That wasn't Parkinson's disease. It's the levodopa acting on the degenerating dopamine system causes dyskinesias. And that anyone that, let's say 40 or 45 or 50, I would use an agonist first. And eventually, if the agonists fail to alleviate the symptoms, I introduce a levodopa in addition to the agonist. And there's a few, so to summarize again, why do some doctors start off with a dopamine agonist? It means a drug that acts like dopamine or synthetic dopamine, versus the true precursor of dopamine, which everyone would say that's the natural way to go, right? Because you're just feeding the precursor to the natural neurotransmitter, dopamine. The problem with flooding the system with a lot of levodopa is that one can develop an increased sensitivity to that drug that results in excessive movements in the opposite direction. So whereas Parkinson's disease is characterized by slowness of movement and rigidity, an overreaction to levodopa is excessive movement, quick movements, and sometimes even fast movement of the mind, leading to hallucinations and confusion too. So this is one of the side effects of levodopa. However, if you overdose with dopamine agonists, you can also have hallucinations, rapid thinking, and quick movements. It's less likely in a young person. However, if there's an underlying cognitive decline, and I haven't mentioned anything about the association of decline in thinking with the development of the movement disorder, but that's an important consideration. Those patients who have some cognitive decline, which has the broad definition of rubric of dementia. Dementia doesn't mean you lose your mind so much. I mean, that's what dementia, you're demented. It means that you've had a decline in some aspect of your thinking. And thinking is pretty complicated. I could spend a few hours talking about what is thinking, what is consciousness, what is a dream, what are you listening to? Is this a dream or not? I don't know. Sometimes I ask myself that. Where are we? and those are thoughts that I used to have in college, and we'd have hours of existential discussions. But the fact is that as we get older, some domains of thinking are declining. So, for example, visual spatial perceptions, very early decline in Parkinson's disease. The other big important cognitive decline in Parkinson's disease that gradually develops, and this is in all cases, is executive function. And what is executive function? Well, it's the ability to plan ahead and follow through, or to multitask. It's the ability to suppress impulses. That's all under the rubric of executive function. It was interesting when Janet Reno was diagnosed with Parkinson's disease, and she was the Attorney General. I was a fellow in movement disorders, and my mentor, Bill Weiner, actually saw her because she was from Miami originally. And they asked, do you think her Parkinson's disease will interfere with her ability to be the Attorney General? Same question was asked of the Pope, who developed Parkinson's disease. Well, you're an executive. You have to multitask. You have to see 3 or 4 steps ahead, almost like a chess player. When you make a move after in your mind, mentally have processed the opponent's move and then your response and the opponent's move, and it gets pretty complicated. Well, yes, Parkinson's disease would interfere with Janet Reno's ability to function as the Attorney General, but everyone was afraid to say that. Same with the Pope. He should have resigned, like Benedict did, but he didn't. he developed this magic potion that I remember that, I say magic, it was a funny story. There was in the social media, blurbs that went around. I think I forget which pope it was that had Parkinson's. I think John the 23rd. Yeah, he had this special fruit concoction he had, and it had a lot of papaya, and supposedly that had improved his symptoms. And I remember in the National Parkinson Foundation newsletter, I was still just started writing for them, and there was a few questions asked. Well, what's in his concoction that cures the disease? And I was able to find out that it's basically a fruit shake, a smoothie, and he put a lot of antioxidants, yellow fruits. And in fact, that might have been beneficial, and I recommend that for everyone to have plenty of natural antioxidants in their diet. So mangoes, papaya, carrots, all that orange-colored food, vitamin C and orange juices, and those all could have an impact on the progression of the illness. But it's a very subtle effect, so no, the Pope didn't have a magic cure. So we're talking about intellectual decline. That happens. The foresight or planning ahead is the second most common in Parkinson's disease is visual spatial perception. And that comes on very early. It can impact your ability to drive, even though patients' reflexes who have Parkinson's disease can be very quick. Even if you're wheelchair bound and rigid, if someone yells fire, the adrenaline just gets you up and you can move for a while. This is why in the 19th century, Parkinson's disease was considered a neurosis, because there are times when someone who's wheelchair bound can all of a sudden move quickly with great alacrity. And so Charcot, who was Freud's teacher, a neurologist in Paris in the late 19th century, said, well, this is clearly a neurosis because the motor apparatus works just fine. Look how quickly he ran out the door when someone said fire. And yet, when you ask them to do something volitionally, they can't do it. So therefore, there's a disconnection between the will to move and the machinery of movement. And he was right, but it wasn't a neurosis, it was lack of a neurochemical material called dopamine that allows for automatic execution of learned motor programs like walking, reaching, all that. So this is why so many so-called psychiatric disorders, when we get to know more about them, turn out to be neurological disorders. It's another reason I always like to tell my students that all of these psychological issues, once we really understand them, and when I say it's psychological issues, thinking. This thinking has for millennia, thinking and dreaming in this immaterial world. I mean, how can you put your finger on a thought? That must be evidence that there's an immortal soul. This is the basis of so many religions. We see our loved ones die and we bury them. We see that all living forms undergo death and a transformation, go back to the earth. But somehow we still have the memories and the thoughts, therefore there must be a spirit world. And my view is that there's a God part of the brain, and this is but it's the reason I'm bringing it up because Parkinson's disease touches on these issues of will and the will to move and the ability to move motorically, is that thinking and consciousness, being aware, is nothing but an emergent property of neural activities. This is, of course, I have a very religious coordinator, and we always argue about it. She believes that, well, I'm not going to get into one's faith, but I basically, as a neuroscientist, have a lot of evidence that if you knock out certain parts of the brain, it affects consciousness. If you knock out one aspect of the brain called the reticular activating system, you're in a coma. And if you stimulate one part of the brain, you can elicit big dreams. You can elicit memories that are so precise. So we know that there's a material, neurological basis for all of these subtle psychological issues. Now, you can still have a great faith of the biblical God, in the biblical God, because you can say, he's the one that made the brain, so of course, he made us in his image. I don't argue with that. All I'm just saying is that as a neuroscientist, I believe that the brain and the interconnections of the neural activities determine consciousness, determine how you move, and so forth. So I want to finish up about how else to treat. So initially we treat with dopamine replacement when the symptoms interfere with function. The choice of the dopamine replacement depends on your age. And if you're demented, some of those drugs can cause hallucinations that seem very real. And partly because the sleep-wakefulness cycle, which is part of a neural function, is disturbed. I've never met a Parkinson's disease patient who has normal sleep. Fragmented, they never have deep sleep, and they have multiple naps during the day because they're tired all the time. And sometimes they'll have vivid dreams that they act out and punch the bed, and if their spouse has to get to the edge of the bed and eventually to another room because it's dangerous. And this is very common. In fact, this disorder of acting out your dreams reflects the abnormal sleep architecture that we see in Parkinson's brains, and is often an antecedent of the motor problems of Parkinson's disease. About 80% of people who go on to develop Parkinson's disease have an underlying sleep disorder. And they also have constipation. They also lose a sense of smell. There's all these prodromal kind of hints that one will develop Parkinson's disease. And what we're trying to develop now are biomarkers that allow us to predict the transition from prodromal Parkinson's disease to clinically diagnosed Parkinson's disease, because that will allow us to intervene at an earlier stage with effective neuroprotective drugs. And that's kind of a big emphasis of research supported by Michael J. Fox, the NIH. But right now, we don't have such good biomarkers. That would be a blood test that one could take and when you're 40 and look at the chances that you're going to develop Parkinson's disease. We know that 10% of cases have Parkinson's disease have genetic risk factors, and so eventually we'll be able to hopefully diagnose the underlying, predict who's going to have the illness. And that would change maybe the lifestyle, maybe the diet, maybe the medicines we would introduce. So one of the major issues that we have with this illness, because we focused since 1960 on dopamine, is dealing with the complications of dopamine therapy. That's most of the patients I deal with have the following problem. That initially 3 tablets of Cinemet will cover them the whole day. They wake up, they do well. But within a few years, each tablet of Cinemet lasts less and less. It isn't that you're becoming tolerant to the drug, or you're developing an immunity. At least many doctors, patients say, am I becoming immune to the drug? No. It's that the illness is advancing. And as it advances, the ability to store dopamine in the dopamine terminals that's made from levodopa diminishes. So the clinical response becomes shorter because your clinical response depends on the circulating blood levels of levodopa. In the beginning, even though the levodopa levels in the blood are gone by 2 or 3 hours, you still have dopamine that was made from that previous dose and stored in your brain that carries you through even though the blood levels are low. But that storage of dopamine continues to decline, and therefore you need to take more levodopa, more often or in higher doses. And as you do that, you increase the risk for what are called peak dose dyskinesia, which are involuntary movements that are dance-like movements, twisting movements, sometimes curling of the toes, that occurs about an hour after taking levodopa. Because your brain, your dopamine receptors have become oversensitive to dopamine because of the flooding of the system with levodopa. It's another reason we like to use dopamine agonists in younger patients. So that is the biggest problem. And so the big solution, one solution, is to give a dopamine agonist that keeps constant stimulation of dopamine receptors around the clock. The only drug I know that can do that at this time is rotigotine or the Nupro patch. So I tend to use that a lot when people are starting to have motor fluctuations. I'll use it right away in a young person, less than 60, because it'll delay the need for levodopa. Now, unfortunately, an agonist by itself is not going to do the trick. Why is that? Because other neurotransmitter systems become involved. The illness goes beyond the nigrostriatal dopamine system. It involves noradrenaline, serotonin, acetylcholine, other neural systems. It involves other parts of the brain beyond the deep gray structures of the brain. So it involves norepinephrine. Therefore, you're going to develop low blood pressure, feeling hot and cold, sweating. Involves serotonin, depression ensues. Depression is often an antedate to disease. Luckily, we have medicines we can use to improve the depression, to improve the blood pressure issues, and nothing that we know of for the hot and cold feelings of the hot night sweats. And then with time, there's a system that becomes involved that involves a brainstem region that's responsible for these repetitive gait movements that is deranged in Parkinson's disease, and that's why people begin to lose their balance. And I think that the University of Florida Movement Disorder Group got a grant from Michael J. Fox to look more carefully at deep brain stimulation of these regions as a way to improve the gait and balance problems. Right now, none of the medicines really will protect you from falls. Dopamine agonists, none of the medicines. Deep brain stimulation is one of the things that we do when people have complex motor fluctuations where the levodopa induces dyskinesias, then it drops off suddenly, you have sudden off. So you have really complex problems that develop to levodopa. In that case, those are the people I then refer for deep brain stimulation. And it's very useful. And there's a target called the subthalamic nucleus, usually unilateral, and you pick the side that's most involved. But eventually, you can have deep brain stimulation of both sides. And in the future, there will be deep brain stimulation just for the more advanced stage for gait and balance problems. I think I'm going to end it there. The transition to death. And it's an unpleasant topic, but I'm getting constant mail and phone calls about planning my funeral. You know, hey, you should look ahead. Don't leave that burden to your children. And I said, well, I'm not ready to do that yet, but you know, it's wise to think about it. Here's what happens. In the days before any medication for Parkinson's disease, people died a lot younger. What they died of in the days before levodopa and dopamine therapy, they died of a fracture, complications of hospitalizations and surgery. When you're in the hospital, you develop hospital-acquired pneumonias, resistant to antibiotics, and usually that is one of the ways that people will die, a common way. Fall, hospitalization, complications of hospitalization. That was the common way. The other way that people die, especially before levodopa, was aspiration pneumonia. And it wasn't that they choked on food while eating. That can happen, they can cough a bit, but it's a silent aspiration because their swallowing mechanism is compromised. And while they're asleep even, they can get some fluids in their lungs, and often it's a silent pneumonia. And in those cases, sometimes they just don't wake up. They have a pneumonia, which causes consolidation of the lungs. Their ventilatory rate, volume, like all movements, is small, and they don't get enough oxygen, they won't wake up. That's not a bad way to go. That was not an unusual way in the 19th century. Nowadays, those two ways are still the most common ways to die, but at a normal age. In other words, people with Parkinson's disease now have a life expectancy that is exactly the same as people who don't have Parkinson's disease. The way that people will die, by the way, aspiration pneumonia, or by the way, bladder infections too, that become systemic, or sepsis. It's the other way people will die. And even if you treat with levodopa, you can still develop those same complications, but you have it at the same age, and one lives to the same life expectancy as non-Parkinson patients. Now, I have to tell you that the most common way that people die, if they survive cancer, heart attacks, and strokes, is pneumonia, and falls. So my mother, who lived to 96, had a fall, went to the hospital, had surgery, recovered, fell again, went to the hospital again, developed an aspiration, a pneumonia-resistant antibody, and she died. So from the first fall to her death was about 3 months. And she didn't have Parkinson's disease, she was very healthy, didn't have cancer, so this is not an unusual way to meet your mate. Falls and pneumonia. So that's why everybody with Parkinson's disease needs to have physical therapy with attention to gait and balance and education about how to prevent falls. And don't forget that even though you might feel really good, you can still fall. So be careful about that. Now there's a question here, and then there's a question that says, is there any connection between PD and temporary eyesight becoming blurry, or is this related to blood pressure, which may cause the eyesight to become blurry? Well, if the blood pressure is low, you'll also feel lightheaded. So yeah, I mean, just before you faint, you might black out, so you don't see anything. But usually, blurry vision is not an unusual complaint in Parkinson's disease, and it's due to several factors. First of all, many of the drugs, especially the drugs that we use to control tremor, which I didn't mention, by the way, I could talk a bit about that, like Artane and Cogentin. I don't use too much in people over 60 because they can interfere with short-term memory. But they cause blurring. They prevent your lens from adjusting to near vision. So you have problems with near vision in particular. But the most common reason, independent of medication, is the best way to say it is due to the rigidity of the eye muscles. Think of it this way. Our eyes are yoked like a pair of horses. And if one horse is pulling too much, it's going to mess up the direction of which the cart is driven, right? So if one eye has a lot more rigid muscles than the other, which is usually the case because the illness is asymmetric, so one eye will be slightly deviated just a fraction, and that slight deviation will cause either blurred vision or double vision. If it's really deviated, where you have really pronounced rigidity of the eye muscles on one side, you'll have double vision. Those cases I send to a neuro-ophthalmologist. They'll determine whether it's constantly double vision or only as the drug is wearing off. Because double vision can be corrected by prisms, but if your double vision varies as a function of levodopa, it's pointless to get your vision corrected. The thing is to try to adjust the medication so you don't exaggerate the asymmetry of the rigidity of the eye muscles. Yeah, so that is not an unusual problem. So there's other things that happen with vision. The retina, which has dopamine neurons, degenerates and becomes very thin. And that lack of dopamine neurons in the retina, which transduces light energy into electrical neural energy and conducts it to the occipital lobe, that ability is diminished, but how it reflects, how it's manifested is in decline in contrast sensitivity, which is one of the visual issues that happens in Parkinson's that you might consider blurring. And what it is you might have your eyes refracted and you can read the Snell chart, but if you're given a different test of acuity called contrast sensitivity test, and it's kind of a test where they give you, it's kind of like a barcode, a thick line gets thinner and thinner and thinner until it becomes very thin, and you're asked to see where you can distinguish the black from the white line. And in Parkinson's patients, even with their best eye glasses and corrected, do not have very good contrast sensitivity. What that translates to is some kind of blurring of vision. You should read with very bright light, and some difficulty discerning shades of gray. Not 50 shades of gray, but driving at dusk in London in the fog would be really crazy for someone with Parkinson's disease, because you wouldn't be able to tell if there's anything in the road. So shades of gray would be difficult to discern. And that's the other visual common problem. Now I'll take one question, because I have, yeah, go ahead. Okay.
wondering about the increasing anxiety and level of stress that one seems to take over when you have Parkinson's.
That's an interesting question. We know that depression is very common in illness, and depression has a brother called anxiety, and often they're together. It's anxiety, depression. The anxiety gets worse as you're wearing off, so it's considered to be one of the non-motor manifestations of the illness. And there's this kind of panic or fear or anxiety. Anxiety, by the way, is due to anticipation. There's a really great Confucian saying, if you live in the future, you're anxious. If you live in the past, you're depressed. If you live in the moment, you're at peace. So people who are always anticipating, and people who take Cinemat, because they know the Cinemat's going to wear off, they're anticipating that wearing off, waiting for the next, they develop terrible panic, anxiety, and in the old days, we were very liberal with Valium and Librium for these people. That's worse, because what that does is make you depressed, you're dwelling. And so if we use Valium and Librium to deal with the anxiety of anticipating wearing off, you're going to make people more depressed, so we don't. The thing to do is prevent the wearing off, make the motor response smooth. That'll alleviate the anxiety. And there are antidepressants that affect both anxiety and depression, or agitated depression, we call it. So adjusting the antidepressant will help. No more questions? I have to see my first patient at 1. Too late.
Help me thank Dr. Ramos, will you? Okay. Thank you, Dr. Ramos.